See less bone resection and operative trauma. It prevents posterior tibial displacement, preserves normal femoral rollback, preserves PCL proprioception, so it makes the knee feel more normal with a better stability throughout range of motion. It can be used in a cementless technique without cement, and for all these reasons, I feel that may be a better option for active and athletic patients. It also will avoid some of the complications and problems with posterior stabilized total knee arthroplasty, such as cam peg impingement, dislocation, patella clunk, and anterior knee pain. Now, why would you want to remove the posterior cruciate ligament, especially after you spent all day learning about how to save and reconstruct it? You would have to ask those posterior stabilized surgeons. They will probably say that it's easier to do, it's quicker, it's more consistent, reproducible. They have, at least in the past, noted to have more range of motion. And they will also say that it is difficult to save the PCL in its function consistently. But what if I could tell you you could consistently and easily reestablish the normal joint line and preserve the PCL in its function? The traditional methods of getting more motion when you're saving the PCL have been to resect more bone posteriorly on the femoral condyles, to increase the posterior slope on the proximal tibia, and to recess the PCL or to do more releases of that ligament. However, I will say to you that each of these, while they may increase the motion of that knee arthroplasty, they also have negative consequences. And in doing so, they actually may prevent the PCL from functioning properly and prevent the total knee to perform correctly. Let's go back to some literature. Shannon wrote in the Journal of Bone and Joint Surgery in 2007 this article about how we preserve the PCL in total knee arthroplasty. It's quite interesting. They looked at pre-op MRIs and post-op lateral knee radiographs. And what they tried to determine was where the proximal tibial osteotomy or cut was made in reference to the footprint of the PCL on the posterior part of the tibia. And what they found, interestingly enough, was that 17 of the 22 patients that they looked at, there was at least partial disruption of the PCL. And 8 of the 22, in these cruciate retained knees where you're supposed to save the posterior cruciate ligament, they found that 8 of the 22, the proximal tibial osteotomy was actually below the footprint of the PCL. And once you cut below the footprint of the PCL, there is no function to that ligament. So, if the PCL is severely cut or injured in greater than 35% and maybe as much as half or more, why do we try to save it, and why does this happen in trying to save it during cruciate retained total knee arthroplasty? We actually did a study a few years ago looking at the impact of the tibial slope on the predicted joint thickness. If you look, let me see if I can do it behind me. This first line here, B, is the natural slope of the tibia. That's what we usually do when we're doing our proximal osteotomies in the past when we tried to retain the cruciate ligament. And that natural slope is usually around 7 to 9 degrees of posterior slope. Now, when you're doing a posterior stabilize, you try to do more neutral cut, 0 to 3 degrees, at most 5 degrees. And so what we try to do on an MRI study is to figure out from the distal cut of the femur to the cut on the tibia, whether it's a natural slope or a neutral slope, how much space was there, the thickness, the predicted thickness of that joint would be. And what we found was that in greater than 92% of the cases, when you make that neutral slope, that 0 to 3 degree slope, there's about 17 millimeter gap. When you do a natural slope and you come above the footprint of the PCL, it measured only 14 millimeters, a difference of 3 millimeters. Now, why is that 3 millimeters so important? Well, that additional thickness, that 3 additional millimeters, really can make it very tight in flexion to get the appropriate range of motion. And so to correct for that, you would either have to increase the thickness of your tibial cut or increase the posterior slope. Now, both of these can actually hurt or damage the footprint of the PCL, making it non-functional. So, in discussing how we can come up with a better way of doing a cruciate retained knee and preserving the function of the PCL, we set up some goals and rationale for our new design. First, you need to identify, preserve, and reference off the PCL. Use the anatomic ligament itself to guide our cuts and reestablish the normal joint line. We also needed to avoid excessive and additional bone cuts as a way of achieving appropriate PCL tension, and we need to avoid ligament release. In addition, this should all provide safe and reproducible kinematics. And what we came up with was a technique called the posterior cruciate referencing technique, or PCRT. Now, this technique assists in preserving the function of the PCL by utilizing it to determine the cuts and to reestablish the joint line and the PCL tension. And then we use a variable sloped tibial insert to adjust the kinematics and the range of motion at the end of the procedure without additional cuts, taking more proximal tibial bone, or increasing your posterior slope. What we do use instead of that, we use techniques and indicators such as the POLO test, P-O-L-O, pull out or lift up, as popularized by Dick Scott in Boston, and also looking at the visual contact of the femur on the tibia, where it should sit in 90 degrees of flexion around the 60-40 mark, where it normally should sit. PCRT predictably identifies the PCL anatomically. It controls the depth and angle of the tibial resection. What we don't do is take an arbitrary 2 millimeters off the low side or 9 millimeters off the high side. We use a stylus to determine the cut to just the beginnings of the PCL footprint. We also, this technique allows for controlled measured resection of the distal femur, which gives us our normal joint line. It protects the PCL throughout the procedure, which is obviously one of the most important things, because we're trying to use it for function of this knee in a cruciate retained knee. And then we use intraoperative adjustments using posterior sloped tibial inserts at 0, 3, and 6 degrees of posterior slope to adjust for appropriate range of motion. So through the adjustment of the thickness of the poly of the trial insert, 9, 11, and 13 millimeters, and using these individually different sloped inserts, 0, 3, and 6, we can adjust for the flexion and extension gaps and get better range of motion. This is a animated view of a knee after cut for a cruciate retained knee. And as you can see right here in the middle, this is a liftoff. As the knee flexes, the polyethylene insert lifts off, which means it's very tight in flexion. Now, if we take the same cuts, no difference in the gaps, but use a plus or a 6-degree posterior slope insert, this is what we see. Same animated, same cuts, and what we're seeing, if you watch here, no liftoff. And you can see on the surgical specimen that the metal base plate and polyethylene insert is flat, and actually it is sitting properly condyles over the tibial base plate. In summary, we have one new product, the CR Slope, which is a variable sloped insert from OptiTrack of Exactech. Two new instruments, the no-touch PCL retractor, which is there to protect the PCL while you're doing your surgical technique, and the PCL stylus, which guides you to cut just at the beginnings of the origin of the insertion of the PCL in the tibia. And this is the one new technique. 2-year clinical data. Obviously, when you come up with something new, you need to prove it. And so what we did was look at a 2-year study from before we implemented the technique and the insert to following up for the first 2 years. And this was started in 2008. So we have 3 groups. First group, CR total knee in the standard technique. This is prior to the implementation of the PCRT and the tibial CR slope. Group 2 was the first 75 to 100 cases. So it's part of our learning curve. And group 3, this next 75 to 100 cases after the learning curve, but still using the technique. And what we looked at the data from the subjects, including demographics, surgical time, length of stay in the hospital, range of motion, and the Oxford Knee Score. The data was complete with 2-year follow-up in 190 patients. Group 1 was 23 patients, Group 2 during the learning curve 85, and Group 3 83 patients. Mean age was roughly the same for all 3 at about 65 years of age. 53% was females. The BMI was 31.3 on the average, and the length of stay was 1.2 days in the hospital. And these patients, 98% or more, went directly home post-op day 1. Surgical time was shorter with this new technique. The first group, average time was about 48 minutes. We're down to about 43 minutes in group 3, and now probably roughly 39 or 40 minutes on the average. These improved surgical times came with familiarity with the instruments, the technique. The instruments are easy to use. There's fewer trays. And once we can get the OR team to be aware of it, the reproducibility was relatively easy to obtain. Flexion was significantly greater in group 3, 129 degrees versus group 1, which is 119 degrees. So we saw a 10-degree increase in flexion, and now we're about 133 to 134 degrees on the average. Here, if you look in this chart, the flexion was considered excellent, 61% greater than 125 degrees, whereas in group 1, prior to this technique, we only had 13%. This is statistically significant. That's a 50% improvement in terms of the degree of excellent range of motion. This increased flexion also correlated, in addition to the better feel, more normal feeling for the patient, to better function and better functional outcome scores. The Oxford knee scores were considered excellent in 70% of the cases. That's less than 20, and about 26% good. So we're looking with this technique at 96% good and excellent results. The learning curve for PCRT and associated instrumentation did not adversely affect the clinical results. Instead, the data indicated a savings in surgical time and a statistically significant increase in flexion and in function. Hence, PCRT allows for easier and consistent PCL retention and appropriate reestablishment of the joint line. It preserves bone and reduces surgical manipulation, and the sloped tibial inserts, in conjunction with the highly congruent knee design of the OptiTrack, allow improvements in flexion, stability, and function. Therefore, the CR total knee arthroplasty, as I described, and this new technique, the PCRT, and the new implant, the CR slope, I think may be a better option, especially in those who are younger, active, and maybe more athletic. Thank you.